So we will turn the mic over to Sydney Fleishman from Northwestern, and she'll be presenting on radiation oncology patient education, a scoping review to identify future directions for scholarship.
Awesome. Hi, everyone. On behalf of my team, thanks for having us here. So there we go. Okay. So starting off with a little bit of background on why we conducted this scoping review on patient education in radiation oncology. So first, patients often have limited knowledge or misconceptions about radiotherapy. Second, education has been demonstrated to improve adherence, reduce anxiety, and help medical decision-making. And third, patients are continually expressing a need for more information. Therefore, the goals of this scoping review were to characterize the state of radiation oncology patient education scholarship, and two, explore future directions for research and development of new patient education interventions. So we started with a PubMed keyword search with the search terms shown here, and that yielded 1,128 articles. These articles underwent abstract and full text screening by 2 independent reviewers, with a third reviewer to settle any disputes. We then conducted a snowball of references of the included articles that underwent the same screenings, which added an additional 25 articles. And after excluding review articles from analysis, we ended up with 236 included articles. So all 236 studies were coded by year, country, level in the 6-step model of educational curriculum development, education topic, and timing within the care continuum. The 115 interventional studies were further coded by experimental or observational, study design, sample size, format of educational material, modified Kirkpatrick level, which is to be explained in a later slide, providers involved, or active versus passive learning. So based on these methods, we coded, tabulated, and analyzed many components for our results. One of the most important coding components was by the levels of the 6-step model of educational curriculum development. There are normally 6 levels, but we grouped these into 1 and 2 and 3 through 6. Levels 1 and 2 were articles that described a needs assessment, whether general or targeted. And these made up 47.5% of studies. Levels 3 through 6 were articles that describe the development, implementation, or evaluation of patient education interventions. And these made up 48.7% of the studies. And this became the interventional group that was further coded. Again, 9 articles also fell into both categories. When we further coded the 115 interventional studies, the case series accounted for 45%, while randomized trials accounted for another 40%. Additionally, active learning, which we defined as where a staff member demonstrated how to use an intervention with the patient, was less common than passive learning, accounting for 40% as opposed to 60% of the interventional studies. Now, on the right, you can see that general overview of treatment was by far the most common educational topic, followed by treatment logistics and toxicity management. Meanwhile, goals and outcomes of care, psychosocial components, and survivorship were much less common, accounting for less than 20% total. We also looked at how the number of interventional studies has changed over time. So as you can see on the left, there's a clear positive trend, which we hope will continue because that means more educational interventions are being developed, tested, and implemented. Now on the right, you can see how we modified the Kirkpatrick 4-level model, which the original model has been used to evaluate educational, training, and learning programs. So the most basic level is reaction, and we define this as how patients felt about the intervention. So this was the most common level, and it had 50 studies. The next level was learning, or assessing whether or not the patients were able to understand or recall the information that was presented to them. Behavior was a more in-depth level, and it assesses if the patient's behavior changed as a result of the intervention. And lastly, the highest level is results, which we defined as the intervention showing improvement in health outcomes, quality of life, or measurable psychosocial outcomes. This was the second most common level, with 30 studies fitting this definition. Furthermore, verbal and print, followed by video, were the most common educational formats of interventions, and some of these studies included multiple types of formats. Additionally, the highest percentage of interventions had no direct staff involved, And if there were staff involved, nurses were the most common, followed then by physicians. So now to discuss some takeaways and remaining needs based on these results. So first, it's a positive sign that we're seeing an increasing number of educational interventions over time. But there is a remaining need to continue increasing this number, as well as make sure that there is interventions across the full spectrum of radiation oncology clinical care, as it was most common for interventions to be taking place before treatment started. Additionally, we found that case series and randomized trials were the most common study designs, but ideally, we can shift this more towards randomized trials. Similarly, reaction and results were the most common modified Kirkpatrick levels, but future studies may want to work towards improving behavior and results, as these are more in-depth, higher levels. And then, given the predominance of passive learning, it would also be interesting to look at and investigate the benefit of active learning and staff involvement, specifically physicians, as they were only the second most common staff involvement. Furthermore, as I mentioned, verbal and print were the most common educational formats of educational delivery, which makes sense given the availability of time, resources, and money that are required for those specific interventions, as opposed to more technologically in-depth. However, as technology develops with AI, virtual reality, and more, this remains a ripe area for future exploration, specifically assessing how specific interventions might work better for certain populations, cancer types, or information types. Some limitations of this study were that we possibly missed some search terms, even though we tried our best to minimize that with our snowball of references. There's always the risk of publication bias. There's variance in interpretation just due to the qualitative nature of the studies. And lastly, limited synthesis of study outcomes. So where do we go from here? Given our findings, some future directions to explore within the radiation oncology patient education space are increasing the proportion of interventional studies, specifically those that are targeting behavior and results. And ideally, these studies are in the form of randomized trials. We can also increase the education on the topics that were less common, such as survivorship, treatment outcomes, and psychosocial components. Another future direction is evaluating new educational modalities as technology progresses and assessing how they fit into development of increasingly personalized patient education. And lastly, conducting a detailed comparison of interventional study outcomes. Each of these steps will build towards the ultimate goal of improving outcomes and experiences for patients in radiotherapy. Here are my references. And thank you so much for listening. Here's mine and my co-first author, Catherine's contact information if you have any questions. And I'll now open it up for questions.